Assalamu alaikum everyone. I am Mohamed Abdalbary, a lecturer and a consultant of nephrology at Mansoura University. Today I am going to talk about the ideal time of initiating dialysis in patients with acute kidney injury. I have no conflict of interest. We know that in certain circumstances, the decision making about starting renal replacement therapy in patients with acute kidney injury is clear. This when we have absolute indication for initiating dialysis like refractory hyperkalemia or potassium level more than 6, or you have a refractory acidemia or metabolic acidosis when pH is less than 7.2, or you have a patient with refractory pulmonary edema due to fluid overload, or you have a patient with severe uremic complications such as bleeding or uremic pericarditis, or even when you have a patient with toxicity from a dialysable drug or toxin. But many critically ill patients develop acute kidney injury without an indication for urgent dialysis or an evidence of expected recovery. This is when the conflict started between early and late dialysis. You will notice that doctors will choose early dialysis initiation for patients who are presented with a more critical condition. And I think I'm at a disadvantage here as a nephrologist because I would prefer to say to the cardiologist or to the intensivist, no need for urgent dialysis. We may not be able to end a debate that started more than 6 decades ago, but Dr. Tishan in 1960 started the idea of prophylactic or early dialysis. The idea was, instead of waiting until complications occur, we can act earlier and start dialysis for patient earlier. And he published it in 1960, a paper about prophylactic hemodialysis in treatment of acute renal failure. You can see here he put some pictures of patients under surgical procedures, and he wants to say that those patients heal faster than the patient with late dialysis. And he said that early dialysis will be the option to the relatively ill rather than to the relatively healthier patients. We have many feared hazards of starting renal replacement therapy in patients with acute kidney injury, and the majority are risk of starting unnecessary dialysis in patients who might recover without dialysis. And also you have a potential risk for increased complication like infection or vascular access problems. You have also a psychological burden on patients and families from starting dialysis. And sometimes you could have a delayed renal recovery if you started renal replacement therapy. But also you have some expected benefits, like then optimizing organ function like the lung, the heart, the GIT, like facilitating other supportive measures if you are giving to this patient IV antibiotics, or oral nutrition, and you don't want him to be overloaded. And also you can prevent the complication associated with acute kidney injury like hyperkalemia. You can minimize the tubular damage of the kidney by uremic toxins. And you can alleviate uremic symptoms like nausea, vomiting, pruritus. Also, you can avoid emergency situation where renal replacement therapy has to be started urgently due to severe hyperkalemia or severe metabolic acidosis that would be with higher risk and complication. So it is a question of benefits versus risk in each patient. But we have a problem which early. We are talking about early versus late initiation of dialysis. So which early and which patients and which type of renal replacement therapy. Most studies used either the KDIGO criteria for acute kidney injury or the rifle criteria. You can see here that starting from stage 2 or 3 in the KDIGO guidelines, or starting from the F stage at the rifle criteria. This is meta-analysis, was published last year, and they put here the early initiation criteria and the delayed initiation criteria in the studies, and you can see that the definition of early and delayed renal replacement therapy were inconsistent in the studies. What I find interesting here is this. You can see that the patient in the early group and the delayed group in this meta-analysis, they have the same age, which could be expected. They have the same gender, but they have the same serum creatinine at starting dialysis. Those are patient with early versus patient with late. So there was no consensus on what is early and what is late. But I think most studies will recruit the patient at stage 3 or at F stage of rifle criteria, and they defining early and late depending on the time of initiation of dialysis. So which patient? We know that in certain patients, like patient who is undergoing cardiac surgery, early dialysis may be better. Here is this is meta-analysis, and you can see it favors early initiation of dialysis for patient with acute kidney injury after cardiac surgery. We have also a meta-analysis, which I think the results still valid till today. It proved that the high-quality studies, the mortality did not differ between early and late initiation of dialysis, but in some low-quality studies, like observational studies, it can favor early initiation of dialysis. We have many observational studies, but we have only 5 important randomized controlled trials in the last 8 years. The first trial is the ELAINE trial, early versus late initiation of renal replacement therapy in critically ill patients with acute kidney injury. It was published in 2016 in JAMA, and it was a single center randomized controlled trial. It included about 231 critical ill patients from a university hospital in Germany, and they defined early as they started dialysis within 8 hours of diagnosis of KDIGO stage 2. So they started very early, earlier than most studies. And they defined late as starting dialysis within 12 hours of stage 3 acute kidney injury or initiation of renal replacement therapy and plasma NIGAL level of more than 150. As you can see here, the early initiation of dialysis significantly reduced the 90-day mortality. The mortality rate in patients with early dialysis was about 39%, while it was 55% in patients who started dialysis late. And they showed that more patients in the early group recovered renal function by the day 90, and the duration of renal replacement therapy and the length of hospital stay were shorter in the early group. But please notice here and remember that 91% in the delayed group received renal replacement therapy at the end. In the same year, just months later, the AKI trial was published in the New England Journal of Medicine, and it was a multi-centric RCT. It included 620 patients with acute kidney injury stage 3 who required mechanical ventilation or catecholamine. Please remember that the patient in the ELAINE trial, most of them were after surgical operation. The patient in the AKI trial, here most of them are critically ill patients, either require mechanical ventilation or require inotropes or both. And then defined the early as the patient started immediately after randomization. This patient on stage 3, so they started later than the ELAINE trial. And the late renal replacement therapy, they started if the patient met one of the following criteria: either hyperkalemia more than 5.5 millimole per liter, metabolic acidosis less than 7.15, pulmonary edema, BUN more than 112, or oliguria more than 72 hours after randomization. You can see here that there was no significant difference in survival between patients who started early and patients who started late in the AKI trial. And the rate of catheter-related bloodstream infection was higher in the early strategy group than the delayed group, could be expected. But the diuresis, which could be a marker of improved kidney function, occurred earlier in the delayed strategy group, so it is contradictory to what ELAINE study showed. And also more patients with the delayed strategy, they stayed free from renal replacement therapy. But please remember here that 49% in the delayed strategy did not need renal replacement therapy compared to less than 10% in the ELIAN trial. 2 years later, the ideal ICU trial was published in New England Journal of Medicine, and it was a multicentric RCT trial from 29 ICUs in France, and it included about 480 patients with early stage septic shock who had severe AKI defined as F stage in the Rifle criteria, and those patients were randomized to either start renal replacement therapy within 12 hours after documentation of failure, or late within 48 hours if renal recovery had not occurred. And as you can see that there is no significant difference in mortality or number of days free from mechanical ventilation or free from vasopressor. There was no significant difference in the length of hospital stay. The primary outcome was 90-day mortality, and there was no significant difference. And also about 38% did not receive renal replacement therapy. So it is less than the percent in the AKI trial, but it is much high than the percentage of patients who did not receive renal replacement therapy in the ELIAN trial. What you can notice here is at least one criteria for urgent renal replacement therapy developed in about 41 patients of delayed strategy or delayed group. And of these 41 patients, 28 patients died. And you can see that the rate of hyperkalemia was more common in the patient with delayed group. Then, 2 years later, we have the START AKI trial. It was, I think, the biggest trial till now. It was a multinational randomized controlled trial. It included about 160 or more hospitals in 15 countries. They recruited patients from October 2015 to September 2019. More than 11,000 patients met the professional eligibility criteria, but of those they included about 3,019 critically ill patients with severe acute kidney injury. And they defined early as renal replacement therapy initiated within 12 hours after met the eligibility criteria. We will talk about them later. And late, the renal replacement therapy would be discouraged until conventional indication had been developed or AKI persisted. You can see here is the flow chart for the START AKI trial. So they included patients with more than 18 years who are admitted to the ICU. The eligibility criteria was that they have creatinine of more than 130 micromole per liter, and men, and at least one of either twofold increase in serum creatinine from baseline, or creatinine increase or urine output less than 6 milli per kg over 12 hours. If they have these criteria, you have to assess if they have exclusion criteria or not. If they have potassium more than 5.5 or serum bicarb less than 15, they are excluded from the study. So this patient would start renal replacement therapy. And if they don't have this exclusion criteria, they continue to assess other exclusion criteria, like if they have a drug overdose requiring renal replacement therapy, like if they lack of commitment to life support, like if there is any renal replacement therapy in the previous 2 months, if the patient has kidney transplantation, if the patient was pre-hospitalized with eGFR less than 20 before, if he have a presence or suspicion of renal obstruction, of RBGN, of vasculitis, of TMA, of acute interstitial nephritis. So all these patients were excluded from the study. If the patient does not have any of these exclusion criteria, so they have to assess if there is any clinical ecobos. So to confirm full eligibility, the patient attending physician will ask it to affirm clinical ecobos by noting that absence of any circumstances that would mandate either immediate initiation of renal replacement therapy or deferral because of likelihood of imminent recovery of kidney function. So renal replacement therapy was performed in about 97% in the accelerated group and 62% in the standard group. And at 90 days, this has occurred in about 44% in the accelerated strategy group and 44% in the standard group. So there was no significant difference in mortality. And among survival, the dependence of renal replacement therapy was a bit higher in the accelerated group, and adverse events occurred more in the accelerated strategy. And as you can see here, there was no significant difference in the survival between patients who were in the accelerated renal replacement therapy or patients who received the standard renal replacement therapy. And also, there was no meaningful difference in the composite outcome of this or dependence of renal replacement therapy, major adverse kidney event at 90 days, or death at the ICU at 28 days, or the length of hospital stay. They also did subgroup analysis depending on gender, estimated GFR, or sepsis, type of ICU admission, and you can see there was no significant difference between accelerated strategy or standard strategy. So in our practice, in our daily practice, I think sometimes we may be later than late. If you look at the number of the ELENA study, they started earlier, of course, but if you look at the number, the median time from stage 2 AKI to renal replacement therapy in the late group was about 25 hours. And the serum creatinine at renal replacement therapy initiation in the late group was about only 2.4. So what about comparing late dialysis versus later dialysis? And this is what the AKI 2 trial answered. So the AKI 2 trial was a follow-up to the original AKI study, and it included patients with oliguria for more than 72 hours or BUN more than 112. Those patients were randomized to either receive renal replacement therapy just after randomization. So those patients, remember that those patients were oliguric for more than 72 hours, or they have a BUN more than 112 milligram per deciliter. So they have absolutely stage 3 AKI for some time. And they were randomized to either a delayed strategy, which of course was a delayed in the AKI, or to a more delayed strategy. So in the more delayed strategy, they only start dialysis when there is urgent indication of renal replacement therapy, or when the BUN is more than 140 milligram per deciliter for 24 hours. And you can see that the mortality at day 60 was higher in the more delayed strategy. This is a summary of the previous studies. You have here the ELENA study. It was the first RCT. Then the AKI study, published in the same year. So the ELENA started early in the KDIGO stage 2 AKI. The AKI started in the KDIGO stage 3. The ideal ICU study used the F criteria of rifle, which is similar to the stage 3 of KDIGO. And you have the START AKIs, it was the biggest trial till now. And you have also the AKI 2 trial, which compared delayed group versus more delayed. So what was known after the AKI 2 trial is delayed renal replacement therapy initiation is not postponed indefinitely. In patients with AKI stage 3 with oliguria of more than 72 hours or BUN more than 112, a longer postponing of renal replacement therapy initiation is associated with a potential harm. And as you can see, the patient in the more delayed group in the AKI study, AKI 2 study, they have less survival. And some patients may be harmed by the delaying renal replacement therapy. So patient in the late delays group, the dialysis group who required renal replacement therapy, they had the highest mortality. In the AKI study, patients who received renal replacement therapy in the delayed group had a higher mortality than those who received renal replacement therapy in the early group. And also in the ideal ICU study, 17% of the delayed group developed a requirement for urgent dialysis, and of these 41 patients, 28 patients died. This could be due to the critical situation of this patient, not because of dialysis, but the message here, if you took your decision to postpone the renal replacement therapy, so do not postpone it more than 72 hours of oliguria or more than a BUN of 112. And when renal replacement therapy is ultimately administered, the earlier is better. But the question is, how we know if patients will eventually need dialysis? This is a difficult question. Maybe by dynamic assessment of clinical condition and the renal function, and you can expect if this patient will need dialysis or not. Maybe in the future using machine learning algorithm, maybe by using new biomarkers like NIGAL, KIM1 or interleukin 18. But you can use some practical tool or some practical test, which is the furosemide stress test. So the furosemide stress test trial showed that 86% of patients who responded to the furosemide stress test could avoid renal replacement therapy. On the other side, 75% of patients who did not respond to the furosemide stress therapy, they eventually needed renal replacement therapy. And there are maybe some calculators you can use. You have here, this is calculator for dialysis risk after cardiac surgery, but it's not well validated. So to conclude, the optimal timing of initiating dialysis remains uncertain, and the decision of renal replacement therapy should be based on a sound clinical judgment. And in AKI stage 3, don't wait more than 72 hours of oliguria or when the BUN is exceeded 112. We agree that the renal replacement therapy can carry a risk to the kidney, and it is similar to the risk that mechanical ventilation can carry to the lung. Sometimes you have to act early, but all times you have to minimize the risk.